Hello. We are delighted to welcome you all to this webinar today, and thank you so much for joining. Before we get started, I'd like to just share two logistical notes. First, both American Sign Language and Spanish interpretation are available for this event. You can select this option through the interpretation icon at the bottom of the Zoom window. You can also turn on the live captioning option. Secondly, the week after the event, we look forward to sharing by email the presentation slides and a link to the event recording and additional resources to support your important work. Today, our wonderful expert presenters will focus on deepening understanding of evidence-based prevent adverse childhood experiences and promote positive childhood experiences as the school year begins.
I'm trying to get in.
It keeps saying that they reach a maximum of 1,000 participants.
Oh, yeah.
My name is Samantha Eigner Trebergy, and I'm the Director of Policy and Strategy for the Office of Early Childhood Development here at the Administration for Children and Families. ACF is part of the Department of Health and Human Services.
You ain't gonna worry about that.
We are charged with promoting We are charged with promoting the social and economic well-being of families, children, individuals, and communities. Our Office of Early Childhood Development provides leadership to support a national agenda focused on young people, their families, and the early care and education workforce. But prior to joining ACF, I led early childhood systems at both the state and city levels. So I'm thrilled to be here with you today to introduce these speakers on such an important topic. Throughout my various roles in government, I have seen the powerful work that can happen when we come together to focus on children and families in a collaborative nature. Today's webinar is a great opportunity to hear about the research showing that positive childhood experiences can have a lifelong impact, and to learn about two states where collaboration is front and center to creating the context for positive experiences across all communities for all children. While today's webinar is by no means limited to a focus on young children, we know that creating positive childhood experiences needs to begin as early as possible. And in order to do that, partnerships across public health and human services are essential. Today, we will hear from 4 speakers, beginning with Phyllis Holdish-Nyland, who is a senior advisor for the prevention of ACEs, adverse childhood experiences, in the Division of Violence Prevention at the CDC. Phyllis will give a brief overview of the ACEs and PCEs and their connection to lifelong health outcomes and evidence-based strategies for preventing ACEs and promoting PCEs in our communities. Next, we will learn more about this work happening in Massachusetts. From Lindsay Sagasta, who is the Child and Youth Prevention Epidemiologist, and Alyssa Anwar, a Childhood Experiences Epidemiologist with the Massachusetts Department of Public Health. Lindsay and Alyssa will highlight key ACEs prevention and PCEs promotion activities happening at the Mass Department of Public Health. Following their presentation, Susan Buttress will discuss the Mississippi Thrive Project, which has enhanced developmental health for children birth to 5. Susan is the former Chief of Division of the Child Development and Behavioral Pediatrics and Medical Director for the Center of Advancement of Youth at UMMC in Jackson, where she is the Professor Emeritus. She is also currently the chairperson of the Mississippi Legislative Appointed State Early Intervention Task Force. Now, I'd like to welcome Phyllis to take it from here and go over some of the research.
Great. Thanks so much, Sam. And we just really deeply appreciate the collaboration with ACF and CDC that has made this webinar possible. I am really honored to be here today to talk with you about what we know about how to prevent adverse childhood experiences and how to promote positive childhood experiences, or PCEs. Next slide, please. At CDC, we define adverse childhood experiences as potentially traumatic events or experiences that occur in childhood. This is birth through age 17. These include experiencing or witnessing violence, experiencing neglect, but also aspects of the child's environment that can undermine their sense of safety, stability, and bonding, such as growing up in a household with substance abuse problems or mental health problems, or parental separation or incarceration. The traditional ACEs, which appear on the left-hand side of the screen, were measured in the original CDC Kaiser ACEs study from 1995 to 1997. These traditional ACEs include physical, emotional, and sexual abuse, physical and emotional neglect, and specific household challenges that you see here. Although the original ACEs study and many of our core ACEs measures include these traditional ACEs, these are not the only types of traumatic experiences that can occur in childhood. We are actually working right now on developing uniform definitions for CDC of ACEs and PCEs that will align us more with others in the field who are already acknowledging the importance of expanding our view of ACEs to include experiences like those listed on the right-hand side of the screen. These expanded ACEs include, but are not limited to, experiencing discrimination, witnessing community violence, experiencing trauma related to safety and stability like housing insecurity or homelessness, and food insecurity. Next slide, please. We know that ACEs have a dose-response relationship with a whole host of lifetime health outcomes that span all of these domains and more. That means that the more ACEs a person experiences in childhood, the greater their risk for developing all these outcomes than someone who has no ACEs or who has experienced fewer ACEs. We used to focus more on the behavioral risk factors as pathways for all of these relationships. Like if a person had more ACEs, they might be more likely to smoke or abuse alcohol, and that could explain their increased risk for cancer. But what we are learning about how trauma and toxic stress affect the developing brain in childhood is revealing that much of the impact of ACEs on mental, physical, and behavioral health across the lifespan can be explained by the effects of ACEs on brain development, the endocrine system, the immune system, and even gene expression. Next slide, please. In 2019, CDC published a vital signs on ACEs, where we examined ACEs data from the BRFSS, or Behavioral Risk Factor Surveillance System, from 25 states, and examined how much we could reduce the following outcomes if we could prevent ACEs. This study found that preventing ACEs has the potential to reduce leading causes of death such as heart disease, cancer, respiratory disease, and diabetes. They also impact risk behaviors and life opportunities. Just to help you read this graphic, this study showed that preventing ACEs could have reduced the number of adults with depression by as much as 44%, up to 21 million avoided cases of depression using 2017 national estimates. Next slide, please. Another important player in the relationship between ACEs and lifelong health outcomes are positive childhood experiences, or PCEs. The research on PCEs and how they directly affect health may interact with ACEs is growing, but it's clear that learning more about PCEs and how we can leverage them to prevent ACEs, mitigate their impacts, and improve health is critical to ensuring that all children have access to safe, stable, nurturing relationships and environments. Next slide, please. This graphic depicts the different ways that PCEs can have impacts on multiple physical, mental, and behavioral health outcomes, as well as life opportunities. At the bottom, we see that PCEs have a direct and positive impact on health outcomes. At the top, we see a path of preventing ACEs. Evidence is emerging that the presence of PCEs prevents ACEs from happening in the first place, thereby having a positive impact on health outcomes. Finally, the middle path is one of mitigation. Evidence suggests that the presence of PCEs can mitigate the negative effects of ACEs on health outcomes, even among those who've already experienced them. Next slide, please. Here are some examples of direct effects on PCEs on important health outcomes based on the evidence. In the interest of time, I'll let you look at those for a second, and then we'll go to the next slide, please. As I mentioned earlier, evidence is emerging that suggests that when people report having high PCEs, even if they have ACEs, their risk of reporting, in this case, depression and mental health problems, is similar to those who have no ACEs. As you can see on this graph, the risk is highest among people who have high numbers of ACEs and report only 0 to 2 PCEs. Next slide, please. Our goal is to create and sustain safe, stable, nurturing relationships and environments for all children and families, and helping all children reach their full health and life potential. Next slide. CDC's ACEs Prevention Resource for Action summarizes what we know about how to prevent ACEs and promote PCEs based on the best available evidence.
There is with this.
If everyone could please mute their
Phyllis, you just muted yourself.
Thank you. All right, next slide, please.
You're muted.
I'm muted. Can you all hear me?
Yes.
I can
not
now, yes.
anymore. You're
Okay,
good.
all right. Thank you very much. All right, sorry about that, everybody. The Preventing ACEs resource tool identifies.
You were requesting everyone else to mute their devices.
Yeah, yes. Can you all hear me though? I keep
Yes,
hearing
now we
people
can.
tell me
I
I'm
can hear
muted.
you.
There are
Okay.
some people that have not muted yet.
Okay. All right. Well, as long as you all can hear me, I'll continue on. This resource for action identifies several strategies that can prevent ACEs from happening in the first place, as well as strategies to mitigate the harms of ACEs. Each strategy contains specific approaches that can advance the strategy and evidence-based programs, policies, and practices that are examples of each approach. You can see the 6 strategies here, and I will run through them and quickly list the approaches on each slide for each strategy on the next few slides. Next slide, please. Strengthening economic supports for families is a multi-generation strategy that addresses the needs of parents and children so that both can succeed and achieve lifelong health and well-being. The 2 approaches under this strategy are strengthening households' financial security and family-friendly work policies. Research shows that parents facing financial hardship are more likely to experience stress, depression, and conflict in their relationships and family, all of which can compromise parenting and increase risk for violence and other ACEs. Policies that strengthen household financial security, such as the Earned Income Tax Credit, child care subsidies, and other forms of temporary assistance, as well as livable wages, can prevent ACEs by increasing economic stability and family income to help parents meet children's basic needs around food, shelter, and medical care, and obtain high-quality childcare. Paid leave can help protect families from losing income related to welcoming a new child or to care for a sick child or family member. Flexible and consistent work schedules can help provide parents with a predictable pattern of work, which makes it easier to access quality childcare, establish consistent routines at home, and spend more quality time with their children. Next slide, please. Changing norms that accept or allow indifference to violence and adversity is the next important strategy in the prevention of ACEs. Research suggests that public education campaigns to help parents understand the cycle of abuse and legislative approaches to reduce corporal punishment can help establish norms around safer, more effective discipline strategies and reduce the harms of harsh physical punishment, and can positively impact parenting practices, reduce children's exposure to parental anger and conflict, and reduce child behavior problems. Bystander approaches and efforts to mobilize men and boys as allies in prevention can be used to change social norms in ways that support healthy relationship behaviors. Such approaches work by fostering healthy norms around the harms of violence with the goal of spreading these social norms through peer networks. They also work by teaching young people skills to safely intervene when they see behavior that puts others at risk, and reinforcing social norms that reduce their own risk for future perpetration. These approaches are associated with reductions in teen dating violence, negative bystander behaviors, and sexual violence victimization and perpetration. Next slide, please. The next strategy focuses on ensuring a strong start for children and paving the way for them to reach their full life potential. Early childhood visitation programs such as Healthy Families America and Nurse Family Partnership can prevent ACEs by providing information, caregiver support, and training about child health, development, and care to families in their homes. These programs have been shown to reduce child abuse and neglect and to improve outcomes for children and their parents. Long-term follow-up of the Nurse Family Partnership Program found effects into adolescence and adulthood for the children in their program, including fewer behavioral problems, higher academic achievement, lower rates of substance abuse, and fewer arrests by age 19. Research suggests that access to affordable, high-quality childcare can reduce child behavior problems, parental stress and depression, and rates of child abuse and neglect. Additionally, increasing access to affordable, high-quality childcare may also reduce child abuse deaths associated with having to leave children at home in the care of unrelated adults. Preschool enrichment with family engagement programs provide high-quality early childhood education and support to economically disadvantaged families to build a strong foundation for children's future learning and development and lower risks for future academic and behavioral problems. Parental involvement is emphasized as critical in the child's development and increasing children's success in school. Children who participate in these programs show better academic outcomes and better mental health, and families demonstrate lower child maltreatment outcomes like lower rates of substantiated cases of child abuse and neglect and fewer out-of-home placements. Next slide, please. Teaching skills to help parents and youth handle stress, manage emotions, foster healthy relationships, and tackle everyday challenges of life is an important part of a comprehensive approach to prevent ACEs. Social and emotional learning approaches, often taught in elementary school, are widely used in the U.S. to enhance interpersonal skills and development. Research demonstrates that they significantly reduce peer violence, substance use, depression and anxiety, suicidal thoughts and attempts, delinquency, and involvement in crime. They are associated with improvements in reading, writing, and math proficiency. These programs can both potentially mitigate the consequences of ACEs among those who've already experienced them and prevent ACEs in adolescence and in the next generation. Programs like CDC's Dating Matters, Safe Dates, and 4th-R teach safe and healthy relationship skills to adolescents. They have been shown to significantly reduce teen dating violence, perpetration, and victimization, and have also been shown to reduce peer violence, weapon carrying, and substance use. The final approach under teaching skills is parent and family relationship approaches. These programs cover developmentally appropriate expectations for child behavior and teach parents behavior management, parental monitoring, problem-solving skills, safe and effective discipline, healthy relationship behaviors, and effective and supportive parent-child communication. They have been shown to reduce child behavior problems, youth substance use, and arrests, and parental stress and depression. They have also been demonstrated to increase parent-child communication, parental involvement and support of youth, and parenting practices like discipline and monitoring and supervision. Next slide, please. The next strategy is about connecting youth to caring adults and productive after-school activities. These connections are important for both preventing ACEs and for buffering against the impact of ACEs for those who've already experienced them. There are many mentoring programs, but Big Brothers Big Sisters is the oldest and best known example. Youth who participate are less likely to skip school, initiate drug and alcohol use, and engage in fighting. They show improvements in academic performance, parent-child relationships, student-teacher relationships, and parental trust. The next approach is after-school programs and activities, and they also provide opportunities for youth to strengthen behavioral, leadership, and academic skills, and to be involved in positive activities. One example is After School Matters, which offers high school students apprenticeship opportunities in technology, science, communication, sports, and the arts. Students show improvements in attitudes towards school, better graduation rates, and reductions in academic failure and risk behaviors like gang activity and drug sales. Next slide, please. This last strategy focuses on timely access to intervention and effective care, support, and treatment for children and families in which ACEs have already occurred to help mitigate the health and behavioral consequences of ACEs, strengthen children's resilience, and break the cycle of adversity. Approaches under this strategy include enhanced primary care, in which children and families are connected with referrals and resources by their healthcare providers. Victim-centered services for children and adult survivors of intimate partner violence, including shelter, housing support, crisis intervention, and connection with other resources. Treatment to lessen the harms of violence exposures for children. Treatment to prevent problem behavior and reduce risk for violence among adolescents who are already demonstrating risky behaviors. And finally, family-centered substance use treatment programs, which simultaneously treat parental substance use problems while addressing the needs of their children with this ACEs exposure. Next slide, please. I just wanted to quickly highlight that on our Veto Violence website, you'll see the website here on the left-hand side of your screen. We have a violence prevention and practice tool. This is an interactive tool that will help communities who are interested in implementing some of these strategies and approaches from the ACEs resource for action and from our other resources for action in their communities. So I just wanted to highlight this. I don't have time to go into all the different aspects of it today, but I did want to flag it for you that it's there if you're interested. Next slide, please. Also on our Veto Violence website, we have 5 different ACEs trainings that you can kind of do at your own pace. The one at the top is the one for general audiences. It has multiple modules. And then the 4 trainings shown at the bottom were developed for profession-specific audiences. So there's one for mental health care providers, one for pediatric healthcare providers, one for educators and those who are working in our schools, and one for faith leaders. Next slide, please. I wanted to briefly mention, and our colleagues from Massachusetts may talk a little bit more about our current ACEs Prevention Programmatic Initiative. This is called Essentials for Childhood, Preventing Adverse Childhood Experiences Through Data to Action. This combines, if you're familiar with previous CDC funding stream, our Essentials for Childhood and our Preventing ACEs Data to Action funding. So this funding started in 2020 or FY23, and we funded 12 recipients for 5 years, pending availability of funding, to build their ACEs and PCEs data infrastructure, to implement 2 primary prevention strategies from the Preventing ACEs resource for action that we just talked about, and to build partnerships with others doing this work to build sustainability. Next slide, please. And then here on this map, you can see where our currently funded 12 recipients are. Our recipients represent organizations from 11 states and 1 tribal nation, which is Chickasaw Nation. I just want to close with a slide from our infographic on ACEs and PCEs, which can also be found on our Veto Violence website, that emphasizes that we must all work together to create a world in which every child can thrive. Next slide, please. So thanks very much for your attention. Sorry about our technical difficulties. And now I'll pass it over to Lindsay and Alyssa from who are from Massachusetts Department of Public Health, which is one of our Essentials grantees, to talk about their work implementing some of these strategies.
Great. Thank you so much, Phyllis, for that wonderful overview of both ACEs and PCEs. Just a flag for everyone, sometimes I do shorthand it to PACEs for positive childhood experiences. So I might interchange PACEs and PCEs, but I am referring to positive childhood experiences. So I'm an epidemiologist at the Mass Department of Public Health, and I'm joined here today with Alyssa Anwar, who is also a childhood experiences epi. And at MDPH, we currently have that EFC PACE D2A funding that Phyllis just mentioned. And we've also had previous years of funding for preventing ACEs and promoting PACEs. Today, I'm going to highlight some of the work we have done and are currently doing with that funding, including some public awareness campaigns we implemented and data to action work. Next slide, please. So here are those 6 strategies and approaches for promoting PACEs and preventing ACEs that Phyllis outlined for us. If you could click for me. At some point with our previous grants or our current grant, we worked on these 4 strategies in Massachusetts. The top 2 gray ones are what I'm going to highlight key aspects of today that we've done. And if you could click one more time. I'm going to start by talking about previous and current work in economic supports for families. This has been one that all of our historical and current grants have focused on. Next slide, please. So in Massachusetts, we have paid family medical leave, and this was fully enacted in 2021. Our work in this strategy is the result of building a strong partnership with our Department of Family Medical Leave, which was also a new department that was created in order to enact PFML by 2021. We have focused on various different outreach and awareness strategies over the course of our grants to promote access to and uptake of paid family medical leave. So you can see several ones listed on this slide. And I want to highlight here on this slide our multilingual public awareness campaign, which you can see an image that we used on the right. So the goal of this campaign was to increase awareness and knowledge of the Massachusetts paid family medical leave, particularly for parents welcoming new children. The primary audience was parents and caregivers with newborns or who are welcoming new children, such as through bonding, fostering, and adopting. Demographic communities with lower rates of access to or knowledge of PFML, and the geographic communities with higher rates of birth and matching those demographic indicators for a statewide campaign. We contracted with a marketing team to use data analyses to geographically hone in on the demographic focus of communities that have languages other than English, higher birth rates, higher rates of unmarried mothers, lower rates of educational attainment, and under the 200% poverty level, all using data from the American Community Survey. From this data, the campaign was then developed for several communications channels, including billboards, Google Display, social media, radio, and print including grocery stores and newspaper prints, in the languages of English, Spanish, Brazilian Portuguese, Haitian Creole, and Simplified Chinese, which all of those languages, the application through the Department of Family Medical Leave is available. The landing page that you can see in the bottom left of that image, which is mass.gov/PFML bonding, is still live if you're interested in learning more and seeing how we created awareness campaign and a landing page to promote paid time off when you need it the most. Next slide, please. So in that previous slide, I was talking a little bit about the completed work that we did in previous funding. And this slide is showing what we're actively working on now with our current funding, which is largely continuing to improve outreach and awareness of access to and knowledge of paid family medical leave. So we're working with a to-be-identified health institution to embed PFML into routine practice, and also developing and implementing a paid family medical leave community ambassador model at the local level in a to-be-determined local community with a local organization. I mentioned here that most of these are to be determined because we're taking a strong data approach to be able to use data available to us to be able to identify and make action and implement these prevention strategies and approaches. With the data, we also are working on enhancing the data we have available to us through a data sharing agreement that would link administrative PFML data with birth certificate data to help understand utilization by leave type and demographics to support program implementation and improvement to ensure equitable access and uptake. Next slide, please. So now I'm going to shift over to highlight a completed awareness campaign that we did within the social norm strategy and approach. Next slide. I see that it's circling. I'll start talking about it. Great. Okay. So to fulfill the promoting social norms to protect against violence and adversity, we launched the Power of Positive Childhood Experiences campaign with the goal of raising awareness of what PACEs are among parents, caregivers, and community members, and the resources that are available to help support them in promoting PACEs. And as Phyllis wonderfully outlined earlier, by promoting PACEs, we are aiming to reduce the impact of trauma and toxic stress on health outcomes. So our primary audience included parents and caregivers ages 25 to 45, families of color, and those living in the DPH identified 20 vaccine equity initiative communities, as we know that these folks have a higher social vulnerability index and have had barriers to access and resources that promote PCEs, including housing, financial benefits, and healthcare due to structural and racial inequities. Through this campaign, we honed into the idea that promoting PCEs and protecting against violence and adversity truly takes a village. So you can see through our visuals to the right that we wanted to convey the idea that all members of a child's community are the puzzle pieces that make a children's health and well-being whole. For our messaging, we wanted to convey that parents and caregivers have the skills and knowledge to promote PCEs in their children's lives, from comforting their children and spending quality time together. But at the same time, we wanted to encourage parents to know that they do not have to promote PCEs alone and can connect with their community for support, whether it's talking to their child's healthcare provider about their child's growth and development, or joining a parent support group to have a safe environment they can share their concerns with and receive emotional support and encouragement. This landing page is also still live at mass.gov/the power of positive childhood experiences. And I encourage you to look at some of the resources we provided from within Massachusetts to parents, caregivers, and community members, and learn more and see how we framed it. Next slide. So I'm going to pass this to my colleague, Alyssa, who's going to talk a little bit more about a data to action project that we did with the CDC funding.
Thanks, Lindsay. Hello, my name is Alyssa Anwar. I'm the Childhood Experiences Epidemiologist. In the second half of our presentation, we want to highlight the data aspect of the CDC funding we have received and a tool we were able to publish, a data dashboard. Next slide, please. Given the public health implications of experiences in childhood that have informed the funding opportunities from the CDC, we set out to develop a comprehensive and digestible public-facing dashboard to depict the current prevalence of ACEs and PCEs among youth in the Commonwealth of Massachusetts. Our goal is to empower communities to use data to inform decision-making surrounding preventing ACEs and promoting PCEs in our state. In our development, we decided that there would not be a specific intended user for the dashboard. It is meant to reach many different audiences that can benefit from using this data, such as those listed on this slide. Next slide, please. The current version of the dashboard includes youth-based surveillance from our Youth Health Survey and our Youth Risk Behavior Survey in Massachusetts, and includes strong racial and health equity framing. Indicators displayed on the dashboard are organized into these 10 domains, as you can see here on these slides. Next slide, please. The website is housed on mass.gov and includes information about PCEs and ACEs, racial and health equity framing, the dashboard, survey information, and other resources. And you can see the content here in our table of contents, which are links that can bring you to each section of the dashboard that you'd like to read. Next slide. This is what the dashboard itself looks like. If you could give us another click, please. Data is grouped into topics, which the user can navigate through the tabs at the top, which you can see in yellow. There is another description of the dashboard and health equity in green. There is a set of filters and tools that can be turned on or off in the pink, purple, magenta color here. Then the actual data display based on the filters the user has selected here in the blue. Next slide. We are excited for the future work to enhance this tool that will use CDC funding to update. We will expand the years of YHS and YRBS on the dashboard, add in more data sources, and continue to enhance our racial and health equity framing supports. We also have a second phase that will focus on bringing in more granular geographic data at the community level. We will link social determinants of health data, and we will identify more data sources to include. We use this dashboard to inform our strategies and approaches rooted in health equity, as well as to engage in data transparency through our roles as data stewards in our public-facing dashboard. To guide our users, we have a data user guide for navigating the tool and navigating the steps they can take from data to action. Additionally, we conduct workshops presenting the dashboard to various audiences. Examples of these workshops we have conducted include at our statewide suicide prevention conference, for our Bureau of Substance Addiction Services conferences, and with staff who implement the YRBS locally within their own school districts. As you can see throughout our presentation, data is a key aspect of our work to promote PCEs and prevent ACEs in Massachusetts, using the strategies and approaches outlined by the CDC. And we are thankful to be able to share our efforts with all of you here today. Next slide. And from here, I will pass it on to Susan. Thank you so much.
Hi, thanks everyone. It's a delight to get to share our Mississippi Thrive project. Next slide. I am a developmental behavioral pediatrician, and I just wanted to disclose that I'm a board mother of 7. And so I'm very interested in making sure all children have a clean start. Next slide. Next slide, please. I'm sorry, would you go back to that one? Yes. Our project, Mississippi Thrive, is what we dubbed it, began in 2017. So you can see part of our project was over COVID, which caused a few bumps. The whole purpose was to improve Mississippi's early child developmental health outcomes through building a statewide developmental and behavioral program. It started off as a 3-year grant and ended up, after HRSA had the insight and we talked with them, that it was really a heavy lift and needed at least 5 years. And we ended up having the grant go for 5+ years. It was a joint cooperative project through 2 of our major universities, the University of Mississippi Medical Center and the Social Science Research Center at Mississippi State University, 2 different areas of the state. Next slide. So this was our aim. Over the course of the project, we really did employ all 6 strategies that you heard so beautifully about from Phyllis to prevent ACEs, to ensure that all children got a really strong start. Specifically, we aim to establish a set of activities to really optimize the behavioral health for all children, to increase the proportion of early childhood providers, both in childcare and in the medical arena, to improve practices with developmental and behavioral health promotion. And then, of course, to increase the number of families who were talking, reading, and singing daily to children. Next slide. So it was a heavy lift. At the time of the start, our developmental screening rate in Mississippi was the lowest in the nation. We did not have enough child health practitioners with intensive training in early childhood. We have our Mississippi Delta and other rural areas with high rates of poverty and a dearth of resources. There was good work going on, but it was siloed. And often there were large grant works going on without knowledge and sharing to others, which was a big problem. And then just to pile on, our early intervention services, IDEA Part C, was in a needs intervention state. Next slide. Next slide, please. We looked at the very beginning at systems change and the dynamics of that. And many of you may know that it's a really complex problem, and it involves movement in many different levels with practices and policies resource flows, relationships, power dynamics. Again, as I mentioned, that siloed work, getting to a real mental model where we had transformative change. Next slide. So the way we approached that, next slide, please. Yes. Our initial work was to first build public and private stakeholder awareness. We worked very hard on this, and you'll see in a few minutes the volume of work that was engaged. We also engaged and educated early childhood professionals in the first couple of years of work. We wanted to improve the quality of our services that were in pediatric primary care, so that was another focus. And then to build workforce capacity. Next slide. So the plan was to increase the number of children and families experiencing that quality developmental behavioral promotion, increase the capacity and number of childhood providers who were doing a good job in this area, increase the number of families, as I already mentioned, in daily talking, reading, and singing to their very young children during early brain development, and then to increase the percentage of high quality services that were provided to children, not just those at risk, but with any young child. Next slide. When you look at policy change, you have to look at it on all these levels that are listed to the left of the slide. And as we were looking at that, we looked at wellness checks. Could they be telehealth in schools, increasing state support for pre-K and getting it down to the 3-year-old level, and then getting support for pediatric care coordination. And we did look at what fed and state legislations and regulations were there. Next slide. These were our primary initiatives. That was the list. But I will say that the outcome of all this was our public outreach messaging was very robust. We partnered with our Mississippi Public Broadcasting System, our American Academy of Pediatrics chapter, the Children's Museum. We developed a very robust website that is still in operation and partnered with a lot of support groups. We were able to obtain sustainable funding for all of those initiatives. And I will say throughout the project, the whole goal was to make sure whatever we set up was sustainable. Next slide. Next slide, please. This is just a screenshot of one of the parts of the website. It's an interactive resource map that we created for providers, families, practitioners, and others, teachers, to look at. So you can hover your mouse over the area, food insecurity issues, and other. Next slide. We worked very hard on our community resource connection, and you could see we attacked it on all 4 levels at the bottom of the screen. And that continues to happen to this day. Next slide. Next slide, please. Okay, our pediatric medical home services that we worked on, we concentrated predominantly on the ambulatory clinics associated with our medical center, and we established an affiliate pilot with Reach Out and Read National. We supported 31 other practices in beginning those programs. And then we developed an accessible now nationally accessible online toolkit for having a robust developmental behavioral program. And you can go to the next slide, please. This is a screenshot of our toolkit. That is the national version. We had one specific for Mississippi with some nuances, and it is all for share. Everyone who is interested in this can access it off our website, which we'll have at the end of this presentation. Next slide. So in workforce development, we established a 1-year post-grad program of intensive training in early child development for medical and allied health professionals. And you can see during the project, we trained 29, we call them fellows for want of a better word, who essentially stayed in the state, all but a couple stayed with in the state to impart services. We were able to get Mississippi legislatively funding for a continuation of that over the next years. And we trained individuals with ECHO trainings, and we used the Mount Sinai training curriculum, Keystones of Development, to also train our pediatric and family practice residents. Next slide. Okay, yeah, I want to talk about, well, we partnered with the ENACT framework to work toward our integrated health system. You can go to the next slide. I want to show you the results of the work that we did on this slide. And you can see at the very beginning, our developmental screening rate was, as I mentioned, at the lowest in the nation at 18%. At the end of the project, we were at national average. To mention is that even though, like I mentioned, it was during COVID and all of our issues dropped somewhat as we were moving along, if you'll look at the child resilience bouncing back after challenges, you can see Mississippi was on up there and slightly above the national average. This was not just from our work, but from the work of all the other groups that did it collectively. Next slide. The only way to make a change is to continue the work. So next slide. And the way we did that was, as they're moving to the next slide, is to continue to partner with others and to try to make us all move forward together. And that, as I mentioned, can be a heavy lift sometimes. You have to continue communication. Next slide. So we established our Early Childhood Development Coalition. That was our advisory board, that, as we called it. So we developed a mission statement, involved additional people. It is very heavily family oriented. Next slide. What we wanted to do as they're moving is to predominantly use Help Me Grow and use the centralized access point. Next slide. And to make it high quality, family centered home services, and make sure families are connected so that they can advance to an integrated, family engaged early childhood health system. So you can see several arms of our work were there. We continue the work. Next slide. And are staying the course. If you want to learn more about our Mississippi Thrive program and our key accomplishments. We have a summative report on this website here. And there are multiple handouts and modules that are available to anyone who wants to access them. Feel free to use them. I would encourage you to do that. So thank you.
Thank you so much, Susan, and thank you, Lindsay and Alyssa, for those great presentations. I think this is so helpful for our audience to hear because we can, we at CDC can talk and ACF can talk about the different strategies and approaches for preventing ACEs and promoting PCEs, but hearing from you all really helps us see kind of what implementation of these strategies looks like kind of on the ground and for actual states and communities. So this is just so helpful. I have just a couple of questions for each of you, maybe one, depending on time. We'll see if we get two in. And the first one is, what advice would you have, and this may center based on your presentations around partnerships, for those who are wanting to implement some of these great initiatives in their community, but don't have funding, like both of you have received from ACF and from CDC to do this work. If people are really wanting to get this off the ground in their communities, and maybe Lindsay and Alyssa, I'll pass it to you first.
Yeah, I can go ahead. I think there's a big connection with a lot of the prevention strategies and approaches to things that might already be going on within a community. So being able to identify perhaps other organizations that have the shared vision or goal. But with our PFML, we had so many different outreach and awareness things that we could just kind of tack on to and be able to add like a flyer to our PRAM survey, which there's a little bit of funding associated with that, but not as much as a major public awareness campaign. So I think being able to really look at all of the different types of examples that go with the strategies and approaches, finding organizations or other entities who in some way are working towards them, such as like our Department of Family Medical Leave with economic supports to families. So, and then creating those shared visions and shared goals with them.
Thank you so much. Susan?
Yeah, along the same lines, I'd just like to mention CDC has so many resources that you can access for free. We were able to obtain a lot of our handouts that we distributed to the clinics through CDC Learn the Signs Act Early. But we also, as I mentioned, partnered with some of our family support groups and our Help Me Grow affiliate to help with the work that we did to increase our developmental screening. They really enhanced their work as they were moving along, and our Children's Museum, our American Academy of Pediatrics Mississippi affiliate chapter actually also joined in and included a lot of our work and recommendations on the website. And like I said, now everything on our website right now is available to any of you. So please use that toolkit if you wish, or any of the handouts or modules.
Great. Thanks so much, Susan. And thanks, Lindsay. And I see that my colleague, Kayla Anderson, has just dropped the Learn the Signs Act Early link in the chat. It's great to have all of these resources kind of available to everyone. So I really appreciate that. We just have a few minutes left, but I'm wondering if hopefully this will be helpful to our listeners and audience. If each of you could describe kind of one challenge that you encountered and how you went about overcoming that challenge and addressing it to move your work forward. And this time, I guess, Susan, I'll start with you.
Yeah, the very first thing I'll have to say is that in the first year or so in our work, we thought we were doing good family engagement. We thought we were. We had involved some family advocacy groups and support groups. But what we realized is that we really truly needed not just those groups, but we needed parents who were in the weeds in all this. And so as we moved along, we made sure that we had parents. We were able to pay them stipends whenever they attended meetings, or we supplied babysitting if we didn't have stipends available. But I would really encourage you all to make sure you involve families. And then the other piece was, again, making sure that people are working all together and not giving policymakers mixed messages about what's the most important, so that you can have a real collective impact and make sure that everybody's moving forward together, because that tended to be a problem too.
Great. Thanks, Susan. And I really appreciate you lifting up, including people with lived experience in this work and figuring out ways to engage them and compensate them. Lindsay, how about you and Alyssa from Massachusetts?
Yeah, I can step in here to continue kind of off the last answer I gave about that shared vision and goals. It was definitely our partnership with our Department of Family and Medical Leave being more administrative human services agency, and them being newer because they were created in order to enact the paid family medical leave benefit, and only had so many years to do that so fully. And it was a really, really big undertaking. So they were doing everything that they needed to do to lift this amazing benefit up and out. So when we approached them, it took a lot to really build that relationship and be able to have that shared vision and goal of how what they're doing by promoting PFML is also a public health thing and strategy to be able to do, to make sure that, considering the social determinants of health, families can have accessibility to the housing, food security that they need. So really just taking a lot of time to build that up before then we really dove into a lot of our major strategies and approaches with them. So really just taking the time, building relationships, and just kind of sharing what public health can do in a partnership with human services.
Great. Thanks, Lindsay. And I do appreciate sort of the recognition of the time it takes to build these different relationships. ACEs is and PCEs kind of are such a broad umbrella, and there are so many different organizations in our communities and in government that really can work together to really address these issues, but not everybody is already working together, and it does take time to build those relationships and those connections and partnerships. So I am recognizing that we are already quickly out of time. I just want to thank our presenters, Lindsay and Alyssa and Susan. I want to thank our collaborators at ACF for co-hosting this webinar with us, and our continued collaboration, and of course all our great interpreters. So I just want to thank you all for coming. There have been lots of resources dropped in the chat. Everyone will receive, and who is registered for this will receive an email with the recording for this event, so that you can watch it again and again at your leisure, and freeze it on links, etc. And then this recording will also live on ACF's website as well. So we just really thank everyone for your interest today. Thank everyone for all the work that you're doing across the country to prevent adverse childhood experiences and promote positive childhood experiences, and really work together to create a place where all children can grow and thrive. So thank you to everyone, and we really appreciate your time and attention today.
Thank you.
Thank you.